should have MCs more often. That was a fantastic introduction. I didn't even recognise myself. Now, it's interesting to note, I'm glad to see that the front has filled up a little. I thought at first the rumours about our legendary halitosis were being taken seriously by all attendees, but it's not true. We've all flossed and brushed our teeth very diligently this morning, so you're all safe, except those wearing rather strange purple hats down the front. I can't vouch for you at all. No, thank you. If you've got a yellow one, I might. Yeah, today I'm going to talk about mainly about the future, but it is. I was reminded. I'm going to talk about the present, obviously, than the future. But I was just that introduction reminded me about the long 6 years that Michael and I, in particular, did spend traipsing the corridors of Parliament and meeting people who really didn't want to meet us. But it's funny, you forget quite quickly. It's however many months it is, 6 months or so since the election, and things have changed. We'll talk about that momentarily, but I was thrust back into the past only a couple of weeks ago on a plane flying from London to Boston. Got on the plane and thought I saw somebody that reminded me of somebody I didn't really want to think about, and said, "No, couldn't possibly be." Sat down, and then all of a sudden this voice that only can be produced by somebody from this city with a strange haircut and glasses could make. And there was Kevin Rudd sat behind me, and apparently he'd been over to make sure that the Ukraine wasn't partitioned. And anyway, it didn't quite work out, obviously, but it did remind me just how dreadful those times were, but how quickly we forget. And indeed, this year has really been quite seen a significant change, at least in opportunity. However, before we could take up that opportunity, further damage was done by the outgoing government with regard to health insurance. The rebate was stripped from lifetime health cover. The effect of that, I don't know that anybody really has been able to work out. But really quite a dangerous thing was introduced, which was changes to the way that the rebate is indexed. Up until the 1st of April this year, the rebate was indexed at the same level as health insurance premium increases. From the 1st of April, that's not going to be the case, and the health insurance rebate, as you know, will be indexed to CPI, or in fact, in the highly unlikely event that health insurance premiums escalate by less than CPI at that level. What that means over time is that the real value of the health insurance rebate will be eroded to a point of almost irrelevance. Now, it's not an issue for today or tomorrow or perhaps even for the day after that, but in 5, 6, 7 years, whatever, this is a real big issue in terms of health insurance participation and just the affordability of health insurance in this country. When you look at what the means testing was doing, that was aimed at people who had the financial ability to continue to buy health insurance. What this will do is knock out people who don't have that same ability, who struggle already to afford health insurance, and this could be, in the fullness of time, quite an issue to us. Unfortunately, due to the fiscal pressures that were at play and remain at play, this was supported by the coalition. But when I come on to what we're actively lobbying for, this, of course, is a key issue that we want to see reversed. Another great issue during the year was around chemotherapy and the sustainability of this hugely important service being able to be provided in the private sector at a rate that was affordable for patients. And I'll cover off more on that later. So just looking at the operating environment as we see it, as you know, despite the introduction of means testing and the rather difficult circumstances around health insurance over the last few years, membership actually remains very strong at around 47% of the population. This comes after some sustained pricing pressure that saw, particularly for, in this example, people in Tier 1 households facing an increase of over 30% over the last 2 years, and still the vast majority of those people have retained the product. The other issue that we thought would play out over the time is that the number of people who took out or take out exclusionary products would escalate The view being, well, given the value proposition of health insurance, given that most people do value it, given the fact that if you earn over a certain amount of money and you drop health insurance, then you end up getting slugged by the ATO. The view really, I think the consensus view was that it was unlikely that lots of people would actually leave. But the view was also that there would be a significant increase in those people who remained in health insurance but decided they either didn't want to or couldn't afford the 30% or whatever it was increase in premium, and that they would effectively dumb down their health insurance by taking out more exclusions. Thus far, certainly from an overall perspective, that hasn't happened yet, in that around about 21-22% of members have exclusionary products. But as we'll talk about later, we can't really see beyond that headline number to see whether or not people have actually increased the number of exclusions that they have under the same product. So we're not really certain as to what that impact has been. However, underpinning all of the businesses that we operate are the positive demographics that we see in this country. We have an expanding and ageing population which will continue to drive demand for healthcare inexorably for the next 30 or 40 years. So we are not an industry that is dying. We are one of the biggest growth industries of the 21st century, and one way or another, the industry at large and whatever sector you represent will do well, in my view, over the long term in this country. So I spoke briefly before, it is a new era, and as I say, it's easy to forget how difficult it was in the preceding years. We now have a government who actually does have a very favourable and positive attitude towards this industry in total and hospitals in particular. It is easy to gain access. It is a pleasure to discuss opportunities to grow this industry with this government. As an association, we've identified a number of key objectives which we've already advocated to the coalition at a prime ministerial level, and of course with Peter Dutton and the wider bureaucracy, and thus far had a very positive response to what we've been talking about. Effectively, what we've tried to do is there are, as always, a myriad of issues in this industry, and finding agreement amongst ourselves as hospital operators, let alone amongst the wider private health community, has always proved elusive, particularly when we've tried to do too many things at once. So what we've tried to do is just hone in on 4 issues to actively promote that really have at least thus far, got universal support. And the first one is a very simple one. Let's get out there and advocate new vehicles, new ways, new policies to grow the pie. It's certainly my view that at 47%, given the current levels of affordability, the carrot and sticks that government have put in place, 47% of the population seems to me a saturation point. Yes, we'll get incremental growth as people move into the bands where they get taxed more if they don't buy health insurance. Yes, we'll get more demand flowing through as a result of the aging nature of the population. But in a material sense, I can't see how the dial's going to move that much with the way the industry is currently structured. So we've set ourselves an aspirational target of shooting for 60% participation across the Australian population, growing into health insurance. When we've sort of surveyed the landscape about where are those missing people, we've got participation at high levels amongst those people who are adversely impacted through taxation if they don't take out health insurance. High levels of participation amongst self-funded retirees, provided they've got income levels above a certain level. Where else in the population could you actually see a large number of people who don't have health insurance currently, but who aspire to do that? And really, that's the workplace. When you think about it, lower paid employees right across Australia, every survey suggests aspire to have health insurance, but can't afford to buy it. So if we can come up with a vehicle that doesn't cannibalise the existing 47% participation, doesn't load up Australian industry with significant costs that make products and services produced here less competitive, doesn't cost, importantly, given the current fiscal circumstances, government a huge amount more than what it's already contributing to the health sector, then we really do have a chance to not only address this opportunity, but in a managed way, because these people are collected together under employment. So we don't have to go and find 2, 3, 4 million people. We have to find maybe 10,000 or 20,000 employers. And there's a whole series of vehicles that we can use to do that. So this is something that's actively being worked on. There are examples around the world of where this has worked quite effectively, one being in South Africa through the government employee medical scheme that was put in place post-apartheid, which has had huge take-up amongst that part of the demographic. So if we can get it right, there's a real opportunity, given that we've got a government that understands the value of addressing this opportunity. There is a real chance that we can make a significant change to participation levels in this country. And as a last point on the slide suggests, there really hasn't been a huge amount of growth over the last 14 years. I really believe that where we are is where we are, unless we can do something materially different. We've got that chance now, and as an association, we're going to take it. On the negative side, there are some things still swirling around in the health insurance sector that have the potential, as I indicated early on, to hurt us. Rebate indexation is the priority, in my view, in terms of trying to get government to repeal that measure. Whatever's happened with means testing, certainly from a first-round effect point of view, I think we've largely seen. We haven't seen huge numbers of people dropping out. We haven't seen, at least from what we can, what's transparent to us, a significant increase in people downgrading their cover. But it may, in some kind of second round effect, it may become more pressing. But there's no doubt that we're sitting on a ticking time bomb with the rebate indexation, and we will continue to lobby strongly that as the first thing that this government should or could do when their fiscal circumstances allow them to do it, is to repeal this indexation measure. We're all grown up. We understand the budget pressures that the government's inherited and has to deal with. And fortunately, at least, this rebate indexation, as I indicated earlier, is not a today issue. But what worries me is that when you have issues that aren't today issues, they never actually get dealt with. And by the time this rebate indexation becomes a today issue, it may already have caused a significant difficulty within the insurer base, which is that much harder to rectify after it's occurred. So it is something that we need to keep front and centre and advocate strongly for repeal rather, as soon as government's able to do so. Okay. So here's one for all the private hospital operators in the room, getting private patients out of public hospitals. This is a significant issue on a number of fronts, and not just in terms of its obvious benefit for private hospitals. Whilst 47% of the population have got health insurance, only 40% of admissions to hospital every year are in private hospitals. So we're not punching at our weight, let alone above our weight as an industry. We're actually underweight significantly. Where is the missing 7%, and why is it missing? And the vast majority of those patients are attending public hospitals, either going in thinking that they're public patients and getting turned into private patients once they get there, or actively going in knowing that they'll be using their private health insurance. Our 47% isn't 47% in terms of utilisation, and we must address that as a sector if we're going to get any meaningful growth in terms of utilisation. As you know, a whole series of perverse incentives exist to encourage public hospitals to I suppose, turn, whatever the word is, public patients into private patients. The states now are addicted to the cash that this brings. We have advocated as an association with all the states in Australia, with the previous federal government and with this government, to do something about this, because it makes no sense right across the spectrum. What it does, not least, is create an unfair playing field for those patients who attend public hospitals who don't have health insurance, because as it stands at the moment, they are becoming second-class citizens in a system that is supposed to be egalitarian and show no difference irrespective of where people are coming from, because there is this chase for money. It must create blockages in the system, but what it is creating also is unsustainability in terms of the level of growth in benefits that health insurers are paying, and creating all sorts of cross-subsidizations. So, doctors in some states get paid twice for treating the patient, once through an hourly rate, and secondly through the hospital actually paying AMA rates for them to treat a private patient in the public hospital. So there's lots of crazy stuff going on, but to a degree, it's our own fault. The vast majority of the patients, I think, who end up, private patients who end up in public hospitals, do so because they go to a public hospital emergency department. And in most places in Australia, the private system is underrepresented in emergency medicine, and we need to fix it. It's one thing for us to go out and talk to government and complain, say it's not fair, it's not fair, it's not fair, these patients shouldn't be in there and it's wrong and they should be coming to us. But we really don't make it that easy for them in many places to actually access private emergency medicine. So we've got to do something about that. Now, we've all done, most of us here have got emergency departments. We all know what the economics of these things are. One of the issues that we've taken up as an association to the federal government is that if you think it's a good thing that the private sector actually pulls its weight in the area of emergency medicine, and just to put it in context, 47% of the population have health insurance, 6% of emergency department separations in the private sector only. So we're way, way, way underweight in this area. And if you think about all the things that have changed in the private sector over the last 20 years or so, we've come from what most people would have described as a cottage industry to be now a large, sophisticated, complex, huge player on the landscape of healthcare in this country. But we've got a part that's missing, and it's emergency medicine. And so both from a funder point of view, because as you're aware, it's not currently, episodes are not currently funded even partially by health insurers, and from a provider point of view, this is something that we should do to make sure that people who buy health insurance have got access to emergency medicine in the same way as they have access to everything else that we do. But also, this is the way that we can stop the flow of patients into public hospitals and take back what we might regard as our own. Where we're low, so there's two elements in terms of, I'm being taken off already.
No.
There is, oh right, okay. Okay, I'm not supposed to say anything more. Anyway, it's all a good idea anyway. So in terms of private hospital, no, we shouldn't have. It doesn't matter. So increased private hospital representation. So we all know that whenever there's a dinner put on in healthcare, we're always the last guest to be invited, if we even get an invitation at all. And it's usually because somebody else pulled out at the last moment. And it makes no sense. We're a huge participant in healthcare in this country. And, we've really got to be the first people at the table, not the last. So, again, the fourth issue that we're lobbying or advocating for is to significantly increase the participation or representation of the private sector on things such as ministerial advisory councils, the Health Workforce Board, the organisation with the longest acronym in history, which is so long that I'd have to finish my speech if I said it, and a whole series of other relevant bodies around the traps. Again, given that we've got a change in view of the sector, at the federal level, we are hopeful that we'll get far more meaningful representation at this level. Okay. Whatever I do, it doesn't work. So they're the top four, but there are a whole series of other issues that the association has been and will continue to right, there we go. Manual's better. There's a whole series of other issues, of course, that have got significant issues for us. I touched before on the exclusionary and restricted product area. Whilst the headline number doesn't appear to have changed as a result of all the stuff around means testing, we really don't know. FIAC only reports the headline number. We, certainly as an association, have got no idea as to what lies beneath that headline number and really what is the size of our market. We go on, it's fantastic, there's 47% of the population have got health insurance, but what proportion of that 47% actually have health insurance they can use in private hospitals? We're really not clear on that level at all. In terms, when you look at APHA research, the significant minority of people with exclusionary products don't know what they are. They don't know what the exclusions are. They're not sure even if they have exclusions. More than half don't know really what they're covered for, and a lot of consumers struggle, particularly in the areas of psychiatry and rehabilitation. A lot of patients struggle to understand, and often in very vulnerable circumstances, to understand whether or not they've got adequate cover or not. Clearly, again, we're all big boys and girls. We understand that in order to have such a significant participation in health insurance in this country, there needs to be a range of products that people can choose from and can afford to participate in the industry. But I think we must be vigilant, not just as hospitals, but as a whole sector, that we don't chip away at the value proposition of private health insurance by removing this, removing that, removing this, removing that. So in the end, people really are buying something that's like a donut. It has something around the outside, but when you actually get to the middle, you're disappointed because it's just air. So it is an issue for us, and it's something that the association will continue to concentrate on. I mentioned the chemotherapy issue that played out over the last year. Fortunately, and perfect timing, the Health Minister has arrived. We're able to secure a new funding arrangement from the 1st of January this year. There is a commitment to remove a whole lot of red tape and difficulties around this whole critical area. And apparently, Peter, you've committed to a use of the medication chart and to dispense and claim, which is fantastic. I just wish I knew what it meant. But it sounds good, doesn't it? And I imagine it is. So that was, if you recall, I mean, I make light of it, but this, cancer services provided in the private sector, hugely important issue. This is an area where the sector does punch well above its weight, and there was a serious danger that patients were going to find themselves in all sorts of both clinical and financial difficulties if this issue wasn't resolved. So it's fantastic that it has been. Second tier default, always been a thorny subject, I suppose, particularly for health insurers. It remains so. The Department of Health has flagged issues with us that have been raised by health funds in relation to second tier. As an association, we've advocated strongly that second tier should remain, and indeed that its utilisation is possibly underreported to the department. But this is an issue which is one of those old chestnuts. It won't go away. But as an association, we have to stick very close to our members and to ensuring that our members are protected by the continuation of second tier. Workforce and training is another huge area for us, and again I would suggest an area where, generally speaking, the role and contribution indeed of the private sector is under-recognised. I know from our own organisation just how much goes on, and I know from reading about other organisations there is a huge amount now, and growing rapidly, amount of workforce education and training that takes place in the private hospital sector. One of the challenges that we all face, of course, is that whilst I believe most of us are willing and able participants in this very important area, often it's quite hard to actually get the funds to follow the placement. Again, as an association, we're working hard in this area to ensure that we are able to do what I think we should do in terms of taking part in this important area, but that we receive adequate reimbursement for it as well. In terms of how we can improve productivity and innovation and streamline processes for overseas workers, again, that's something that we continue to strive for. I mean, we're in a funny situation at the moment, particularly with nursing, as you know, where right now a whole number of graduate nurses can't find jobs, but we all know when we look at graphs about where workforce is going that we are facing a big problem. It's been pushed out for various reasons, but at some point in the next 10, 15 years, whatever it is, there is a huge gap between need and what will be available through traditional means in terms of nurses in this country. So it's something that as an industry and indeed individual industry participants we simply can't ignore, and we must do whatever we can in association with all other parts of the sector to make sure that we bridge that gap over the coming years. A couple of other issues before I finish. Pharmacy has become quite an issue for a number of participants in the sector. There is a pharmacy guild that generally doesn't look at hospital-based pharmacy in the same positive light as it does retail pharmacy. We must make sure that our hospital pharmacies are appropriately advocated and that we do secure the viability of clinical pharmacy in our hospitals, both at a Section 90 and Section 94 level. And where we can, remove red tape and make it easier for us to provide this vital service to our patients. Finally, prostheses, another old chestnut. This is a critical area for all of us in the room. Yes, there are always issues in terms of affordability, but the key thing here is that we are able to ensure that our patients are able to access new technologies at an affordable level. We shouldn't take our eye off the ball. We all have different sectoral interests in terms of this particular topic, but at the end of the day, what we should be trying to do as a sector is make sure that we're right at the cutting edge of what's available clinically and that our patients get access to that and it's affordable. So finally, the politics of healthcare remain dynamic. Well, that could have been the dot point for the last 100 years and it will be for the next 100 years. So nothing changing there. What has changed, though, is that we now have a real opportunity to work constructively with the new federal government, which we certainly didn't have for a number of years before that. The association, I think, has got some great ideas. We're not coming to government just with complaints or, this isn't fair or we need to change that. We're going to go to government. We have already gone to government with, I think, great ideas to really change things in this industry, to assist government in its challenging issue of funding and ensuring adequate provision of healthcare into the future in this country, and we'll continue to do that. And I'm delighted, Peter Dutton, Health Minister, obviously in the room, but the response so far has been very positive. So we'll continue to play out all the things I've spoken about this morning and make sure that as an association we continue to look after our collective interests, but also the interests of the collective at large, but being the Australian population and particularly those ones who've done the right thing and taken out health insurance. So in closing, I just want to give a great vote of thanks to Michael and all his team. I think the Secretariat of the APHA does a fantastic job with very limited resources. I've worked closely with Michael and his team over the last few years and found them to be excellent, and we are very fortunate that we have got those professionals in place helping us try to achieve the things that we want to achieve. So Michael, thank you. Thanks everybody. Hope you have a great conference.